Before we get started, I just want to review a few housekeeping items and let everyone know how you can participate in today's event. So right now we're looking at an example of the GoToWebinar attendee interface, which is made up of two parts. We have the viewer window on the left, which allows you to see everything the presenter will share on their screen, and the control panel on the right. Within that control panel is how you can participate in today's event, so we're going to look at that a little more closely. So the orange arrow will help you open and close your control panel. And the audio pane provides audio information if you'd like to participate during our question and answer session with audio. Then you just need to use the dial code, the access code, and the audio pin, and you'll be able to participate that way. You can also submit questions via the questions pane. Just type in your questions and we'll read them out to the presenters during the question and answer session. And just a reminder, after the webinar is finished, a link to the recording and PowerPoints will be sent around, as well as an evaluation for CME credit for those who are eligible. Now I'm going to pass it along to Dr. Corey, who's going to give a brief introduction before our presenters start.
Great. Thanks very much, Audrey. We do have a wonderful webinar planned today. As many of you are probably aware, the AARC network has an internal request for applications process through which we stimulate and promote new research proposals. Our most recent RFA, number 7, has 3 studies that are going to be presented at today's webinar. Our first one is bone accrual rates in boys with autism spectrum disorder, and this will be presented by Dr. Ann Newmeyer from the Lurie Center at Mass General Hospital. Dr. Newmeyer is a neurologist who deals a great deal with the autism population, and she'll be sharing her work with us today. Ann?
Hey there. So it's a pleasure to speak and to have received this research funding from the AARC. I'm actually working on part 2 of a project that I started 4 years ago, looking at bone mass in children with autism spectrum disorder. And I've been working on this project with Madhusmita Misra, who's a pediatric endocrinologist and bone researcher, along with Nataya Kano-Sokolov, who's a research fellow, and Dr. Christopher McDougall, who's the director of the Lurie Center for Autism. So, what I'll do first is just give you a little introduction to bone, since most of us aren't bone researchers. And it's important to note that the most important time for bone development is during adolescence, when bone mass increases and you reach your eventual peak bone mass after puberty. So you can see that the bone mineral content increases over time, and especially is increasing during the pubertal years. And growth factors such as growth hormone and IGF-1 and estrogen all influence bone development. And normal bone mass accrual is necessary to occur during adolescence. So there are certain mechanisms that underlie bone mineral accrual in normal adolescence, and those include the presence of growth factors such as growth hormone, IGF-1, estrogen, adequate calcium, good nutrition, genetics, because some people are just born to have slender or poorly mineralized bones, and some people are genetically programmed to have very dense bone. Physical activity, as you know, improves bone, and there are other factors as well. And these factors can influence the formation or the resorption of bone. Oops. There we go. So children with autism have a high prevalence of conditions that are known to affect peak bone mass, and these include gastrointestinal issues. For example, children with celiac disease are known to have low bone density. nutritional inadequacies, looking at the diet of children with autism, which is often deficient in calcium. Low muscle tone and decreased exercise are also known to decrease peak bone mass. Certain medications, including seizure medications and antipsychotics, and SSRIs can also affect bone mass, and their metabolic and hormonal differences, which may also affect the bone mass. So in the first phase of this study, as I started out, we evaluated the bone of 20 boys with autism and 20 typical controls, and we found that the bone mineral density is lower in boys with autism compared to the controls at the spine, femoral neck, and total hip. And so what that looks like is that in typical boys, you can see that their BMD, or their bone mineral density scores, were hovering around 0, and the Z-scores were at -1 with a sensitive, and these results were significant at the spine, the total hip, and femoral neck. Femoral neck is important because that specifically relates to hip fractures later on. So what's more important is that we found that there were some associations within this group who had a lower bone mineral density. And those children who had low vitamin intake from food tended to have lower bone. If the exercise activity was lower, then they had lower bone mineral density. And if they had a restricted diet with low calcium, then they had lower bone mineral density. We also found that nocturnal salivary cortisol is higher in children with autistic boys, but that did not predict bone mineral density. So after we did this study, we started to wonder, well, is there any real difference in fractures? If the children with autism have a lower bone density, do they have more fractures? So we looked at a national database, and it's called the National Emergency Department Sample, NEDS. And that sample looks at emergency rooms over across the country, actually, and they looked at 28 million emergency room visits in 96 hospitals. And we looked, and what we found is that there was a higher odds ratio of hip fractures in children and adults with autism. And so that's very important, because one of our concerns is if the low bone density is significant or not, and this shows us that it may in fact be significant. We also found that there was a higher odds ratio of forearm and spine fractures in women ages 23 to 50. So our hypothesis was, and continues to be, that children continue to have a low bone mineral density in the spine and the hip compared to typical children, that their rate of bone accrual, or bone formation, is decreased compared to typical boys, and that the bone microarchitecture and strength of the bone is reduced compared to typical children. So how are we going to study that? What we tried to do is, and what we're continuing to do, is we're going to study the 20 boys with autism and 20 age-matched controls. Now they're between 8 and 17 years of age. When they initially started the study, we excluded children who were taking medications that directly affected bone metabolism. We also excluded boys who had diseases known to affect bone mineral density, like celiac disease. We excluded boys that were below the 3rd percentile or above the 97th percentile, and we excluded boys that couldn't stay still for the 32nd DEXA scan. Now, over time, some of the boys did start medications that were known to affect bone mineral density, and we decided to include them. So the boys had their first visit between 2009 and 2011. And most of it was in 2011. And now, 4 years later, they're coming back for visit 2. So the measures that we use to study the boys include the bone age, which is just a hand film. And then we did a bone mineral density test, which is called the DEXA. And they just basically lie for 30 seconds, and images are taken of their bones. And the bone density is calculated. And then we're doing a body composition, which is also done at the same time as they do the DEXA, which studies the amount of fat that the children have relative to muscle mass. And then we're doing the high-resolution peripheral quantitative CT, and don't ask me to say that fast. And that study looks at food diary, GI symptoms inventory, medical history, physical activities questionnaire to determine their level of exercise, salivary cortisol in the morning and night, and then serum testing to include some markers of bone formation and breakdown, vitamin D levels, calcium, thyroid studies, because those affect bone development, IGF-1 and testosterone. And for all of these blood tests that we're collecting and hormones, we're looking to see if we can find a correlation between their presence, elevation, or decrease, and the bone density. So this is our timeline for the study. And here we are at the beginning of July. And we have contacted and enrolled all our studies, and we are in the completion phase. We've got a couple kids that we're doing this week, and next week I think we have 1 or 2 boys who moved too much during one of their scans that are coming back to have it redone. And we are putting the data right now into the computer, so we're not quite there yet. So here we've completed 15 of our study subjects and 19 controls. So that was last week when I wrote this. So I think our 5 autism subjects, I think they're done this week, and our healthy controls are all done. Our challenges have been this year recontacting the subjects, and some of them have moved away and some of them had no interest. Scheduling with all the snow and school changes that we had up here in Boston. And our subjects are now adolescents, so they had different interest levels and abilities to sit still. So we don't have any findings that I can report because we haven't put all of our data yet into the computer, but when I sign off on every DEXA scan, it appears to me that we're still looking at a decrease in bone mineral density towards controls, compared to controls. And what will be interesting is to then look at whether the accrual rate is lower in those boys, or whether the accrual is similar, but just the overall density is still decreased. We batch all our blood testing except for the vitamin D and calcium levels, and so we won't be able to look at those until the middle of July when we get our results. So this is a boy who is undergoing a DEXA scan, just so you can see what it looks like, and it's very easy, and they didn't mind it. And this is our center, and thank you very much. If you have any questions, I'd be happy to answer them now.
Thank you so much, Anne. Did anyone have any questions for Anne, we have a little bit of time for some question and answer before we move on to our next presenter. Okay. I don't have any questions right now. If folks want to think about questions, and then we can revisit it at the end of our presentation, that would be great. And if not, then we can. Okay, then we can go ahead and move on to our next presenter.
Great. So our next presenter this afternoon is going to be Dr. Jeannie Van Cleve, who's going to be presenting on expanding capacity of primary care to care for children with autism spectrum disorder. I think that the slides are turned over to Dr. Van Cleve, so you can forward this at this point. There we go.
Thank you for giving me the opportunity to speak about the research today. And I'm grateful for the funding that I've received to do this very interesting work. At least it's interesting to me. I would like to thank my research team, my collaborators, Ann Newmeyer, who you just heard from, and then also Karen Kuhlthau, and Chloe Holyfield is the research assistant on this project. So just some background. Children with autism are increasingly common in pediatric primary care. Children with autism also face long waits for appointments with specialists, as probably most everyone listening to this knows. They often travel long distance to see specialists, and when they do get to those specialists, the environment is less familiar to them because they're there less frequently, and then also sometimes they're there for the first time. However, children with autism have multiple medical problems that are often beyond the scope of the average primary care physician, but the kinds of conditions that they have are conditions that primary care doctors deal with for children who do not have autism. So there are lots of new tools in primary care for managing chronic conditions generally. So here are some that can be applied to autism, and that once you start using them in primary care for other conditions, it's sometimes easy to add on a condition to a platform that you already have. So for example, many guidelines have been developed for different conditions, and guidelines for addressing certain problems with children with autism have also been developed. Electronic medical records with clinical decision support means that within the medical record you can access, the physician can access some sort of either clinical pathway or clinical frequently asked questions or something that helps them make decisions at the point of care. And you can incorporate guidelines into clinical decision support mechanisms to help the physicians where they're most likely to have to make those decisions. Also, a lot of practices are going toward team-based care, which means that not only is there a primary care doctor taking care of patients, but that primary care doctor also enlists the help of medical assistants and nurses in ways that move beyond just the care that's actually in the office. So following patients over time, calling patients for follow-up, and keeping better track over time of the different things that patients need. And this is also where care coordination comes in. So primary care doctors obviously are very busy, but when you have somebody helping to coordinate the care, working with schools, getting in touch with community resources, it's very helpful. Also, in addition to guidelines and clinical decision support tools, sometimes these things come in packaged toolkits that are easier to implement because they already have some of the tools, such as like checklists and pathways already developed. And when the toolkits are endorsed by an organization that's trustworthy, the primary care physician is more, feels more comfortable taking on the care that is specified in these toolkits. Also, there's phone-based specialty advice for mental health that has been developed, and it's proposed as one of the mechanisms that primary care doctors can get specialty advice without having to refer a patient in to be seen. And this specialty advice is usually, it takes the form of when you have a question for a patient that you're seeing in the office, you can page the specialist and talk about the case briefly. And when it's, lots of tertiary care centers have this service, but when it's sort of ingrained in the primary care practice, it can become a little easier to use. Also, when you train specialists to how to best answer calls by primary care doctors, the primary care doctors really appreciate that. Let me make sure this is my next slide. Yes. Okay. So the primary care environment is changing rather quickly, and there are lots of external forces that are modifying the way that primary care is going to be doing its business. So for one, there is an expansion of electronic medical records, and that's been a big point in the policy arena over the past 3 or 4 years. There's also becoming the business case for enhanced medical home services, or really developing this team-based care and paying for the workforce capacity to carry out these activities. Also, there have been a lot of quality improvement initiatives, and the science behind quality improvement has really taken off. And a lot of offices will now have quality improvement teams or a quality improvement champion or specialist. Also, we're improving our ability to measure patient-reported outcomes, which I think will be become important, especially if primary care doctors are reimbursed in part based on how they do on patient-reported outcomes. There's also becoming the business case for population health through accountable care organizations. So these are organizations where primary care doctors will get a set amount to care for a large population. And within that structure, there is the incentive to optimize health while minimizing the costs. So the objective for this research program is to develop a program for primary care providers rooted in implementation science theory that guides practices toward better quality of care for autism spectrum disorders. And I know this sounds kind of vague, but what we're hoping to build are 3 or 4 specific things that we can implement in primary care to really change the kind of care and the capacity of care that primary care doctors can deliver. So our specific aims, number 1, is to explore the perspectives on achieving high-quality care for children with autism using a program that combines the primary care specialist communication enhancements and a toolkit clinical pathway implementation. And then our second aim is to develop an intervention in which these models are used in a unified complementary approach to expand the capacity of primary care to address common health concerns of patients with autism spectrum disorders. So our aim 1, the main method is a qualitative approach. So our rationale is the decision to adopt and make new practices routine is complex, and interviews versus like other things like surveys or surveys would allow participants to explain these complex processes in depth. So this is an approach where we are interviewing 40 to 60 people in 4 different groups. We are interviewing specialists, primary care physicians, primary care staff, and parents or older patients with autism spectrum disorders. And we're aiming to do 40 to 60 interviews total. So what we were aiming to do with this particular approach is to really get the spectrum of people's different experiences. And since the primary care specialty interface is likely to happen at specialty centers, we recruited through 5 ATN sites, and we sought out the directors of these sites who suggested specialists associated with the site, and also primary care physicians who refer to the site. And then primary care physicians, we asked them to recruit some staff and patients. And the initial idea with this was that we would, by interviewing several people who were identified with the same practice and specialty center, we would be able to compare the perceptions of different people in the same site. Interviews have been lasting 30 to 60 minutes. It really depends on how much people have to say about the subject. And we are using a structured interview guide that is generally the same, but is specific for each group, each stakeholder group. So our interview questions, while generally being the same, they are geared to the different role that different people play in the care of children with autism. So specialists, we asked for their perspectives on co-management with PCPs using various modalities, email, phone, and we also asked whether, we asked about their perspectives on ongoing care of patients that they've seen before, and then also answering questions on patients that they haven't seen before, which is, requires a different sort of mindset and a little bit of a different skill set. Of primary care clinicians, we asked about their perspectives on their role, the limits of care of children with autism that they can deliver in the practice, and the overall process of how their practices change what they do. Is it easy or is it difficult to implement changes in their practice, and what are some of the reasons why or why not? Of staff, we're asking about their views on their experience of providing care for children with autism, emphasis on their workflow, routines, and patient-specific variation in the scope of services they feel like they can deliver in primary care, and whether that matches their ideal way that they would like to work, and what are some of the challenges to why the difference between reality and the ideal is there. Of parents, we're asking about expectations and desires for primary care with an emphasis on patient experience and also the scope of care. And we're asking, we're focusing that discussion on, when your child develops a problem, how involved your primary care doctor should be versus a specialist, and in what setting do you prefer and what scope, and how do you prefer your primary care doctor to work with your specialist. So far we've recruited 29 people for interviews, and we've completed 23 of the interviews. And we have interviewed 6 parents, 2 staff, and 21 physicians total. So here are just the next few slides just have some quotes of some of the things that people are saying. So eventually what we're going to do is, or what we're doing actually, is analyzing this data using software that allows you to highlight the different things that people are saying and then attach themes to them or attach codes to them. And then you can look at everything that was said under a certain code and really get the theme of what people are saying. So specialists, this is what one specialist said, but frankly from their end they're not going to sit on the phone trying to get a hold of me anymore. I'm trying to get a hold of them. They don't have time for that either, and our phone system is just as bad as theirs. Another specialist said, so I started out doing a lot of the management myself. The families would come every 3 months to visit. Then the PCP said, I'm comfortable doing this. We transitioned the care to being more at the pediatrician's office. So this talks a little bit about some of, how some of the evolution of co-management occurs, and also some of the logistic barriers of creating a streamlined system by which primary care doctors and specialists can talk to each other easily. So one PCP said, it's just that we don't really see, like asthma, we have guidelines for asthma because we see lots of kids with asthma. ADHD, we see a lot of kids with ADHD. Autistic kids, most of the time, I don't think we see so many of them. And another one said, but the area I feel like I need to learn more and do more on is the nutrition screenings, because the nutrition tends to be a big concern for me, and I want to make sure that I'm addressing all of their nutritional needs, especially for the picky eaters who have autism, that even just, I think it would overlap well into this general primary care practice. So primary care pediatricians are recognizing that this is within the scope of services that they can provide, but sometimes they just don't have the additional knowledge that they need to feel like they're making really good decisions. So here I just listed some of the main things that staff and parents are saying, and this is to not overburden you guys with a bunch of quotes. But what staff are saying is that leadership is very important in the change process. So practices that where the leaders are really emphasizing change, where there's a process for change, those staff are saying very positive things about change and implementing new programs. Also, the workflow is very important, and they emphasize that they're busy and they can't alter the workflow so much. But there is room to do more. Also, a lot of the staff feel that the mission of their practice is very important and something they hold dear, and so making changes or accommodating what children with autism need is within the scope of that mission. There were actually very few staff so far. We haven't interviewed that many staff, but as far as like specific things that they can say that their staff do for all children with autism as a policy or as a general rule in their practice, that was not often mentioned, which I thought was interesting. And parents, what they're saying is that they are very comfortable with the greater involvement of their primary care doctors, and they really appreciate knowing that physicians are communicating with each other, and this is beyond the primary care doctor just reading the report from the specialist. So having a general understanding of what the specialist is thinking and what the primary care doctor is thinking is very important to parents. Also, parents greatly appreciate, I mean, they know when their physician's office is being flexible and individualizing care to their child, and they greatly appreciate those moments when it happens. So our aim too is to develop the intervention, and hopefully this aim will go rather quickly, but it's going to be based on AIM 1 findings using a modified Delphi approach with an advisory board that includes specialists in autism, as well as implementing change in primary care and in using alternative strategies around co-management. So we have, specialists in areas outside of autism that will be helping us with this, and we're hoping to incorporate selective touchbacks with participants in AIM 1 to really round out the intervention. What we're expecting the structure of the intervention to be is somehow coming up with a clinician skills component and creating a process by which clinicians can build their skills over time. And this may be something where the clinician can call the specialist on certain points, or the clinician can, run cases by specialists at scheduled times during the month or a week or something like that, or having a group discussion using some sort of webinar format like we're doing now, so that primary care clinicians and specialists can communicate in a way that helps the primary care clinician then go back to their patient and implement the suggestions. Also, that we expect that there will be an office systems improvement component to this that can implement different tools and different different workflow elements to better serve children with autism. It's good when you do improvements to have discrete, measurable, and achievable practice goals, which hopefully we will incorporate into the program. And then from talking with the primary care doctors, it's pretty obvious there's a variety of practice structures out there, and so any intervention really needs to be adaptable to different structures. And hopefully we can use telehealth and remote learning technology in our program. So some strengths of our project: we are getting multiple perspectives, and we are attending to the implementation difficulties in our program. Some limitations: we may not capture all variation in how primary care practices operate, because I think we are getting a lot of practices who are particularly interested in changing their care for autism, because that's who responds to our requests for interviews. And the intervention may not be adaptable to every practice setting. I mean, there's just so many ways you can make it adaptable, and it may not be able to be used by everyone. And our future directions, hopefully we'll develop something that can be tested in a cluster randomized trial to compare care using the intervention and with some patient-reported outcomes and clinically meaningful outcomes. And with that, I will open it up to questions. Thank you.
Great. Thank you so much, Jeannie. So since we have such a packed schedule today, just in the keeping time in mind, I think we're going to move right on to Kevin Sanders' presentation.
Sounds great. Kevin, you should have control now.
There we go. All right. So thank you for the opportunity to be here. We're really excited about getting to talk a little bit more about our project that we have going on here at Vanderbilt, and very, very grateful for the funding from the AARC that's allowing us to do this. Just to give a little bit of background about me, also I have John here. He's our lead ABA therapist that's working on the project here at Vanderbilt. One of my clinical roles is the director of the Child and Adolescent Psychiatry Consult Service here at Vanderbilt. And over the last couple of years, I've really noticed that our care in the hospital has been far from ideal with a lot of our ASD patients. So we've tried over time different methods and trying ways to optimize. And we've over probably like 3 years ago, we started reaching out a little bit more to our internal resources here at Vanderbilt. And John and his ABA team we noticed that when they were interviewing and helping assist with patients, we were having significantly better outcomes on some of our patients that had been there for a while and been hospitalized. And so we started brainstorming about how we could put this together into something that we could test, and that's where we are with, that's how we came up with this project. So, so we're shifting gears a little bit from the last talk with Jeannie from outpatient to inpatient. And just in general, hospitalizations are tough for all kids, regardless of any neurodevelopmental challenges. But ASD kids have a lot of specific vulnerabilities that make things even more difficult for them. A lot of the kids that we see have significant communication challenges. They have a lot of hypersensitivities to external stimuli, which can be really high in a hospital setting. I mean, if you think about, even typically developing kids can develop ICU psychosis sometimes from the ICU just from all the stimuli that's there. And again, we have kids that rely on their familiar routines, their specific interests that they have, their self-calming techniques that in a hospital setting, a lot of times just aren't there. And so it can make it very challenging for kids with ASD. So what we've seen, over time, seeing these kids in the hospital is that, the stays for these kids sometimes are a lot longer than they need to be. We'll have kids, for instance, that will come in for medical complications, and because of their vulnerabilities in this setting, will develop, behavioral complications on top of the medical complications, and it'll prolong their stay much longer than was initially needed or would have been if we would have been able to manage those behavioral complications better. Also, with this population, sometimes we were seeing use of restraint and seclusion and chemical restraints and sedation with this population when the behavior got to the point where the nurses or the medical staff felt like it was unmanageable. And again, like I mentioned before, just the medical leading to kind of, even in the most extreme situations, to psychiatric hospitalization. So we put this project together, and a little bit about it. We're looking at kids 6 to 18 who have ASD that are hospitalized in 2 different settings here at Vanderbilt, either our children's hospital or our psychiatric hospital. And they're being hospitalized for behavior problems. Either they came in with that behavior problems or behavior problems have developed in response to some kind of treatment they're receiving here. And again, we're looking at 2 different settings, both the psych hospital and the children's hospital. And this is allowing us to kind of compare the models to seeing how the kids might respond in these 2 different settings. Also, we're trying to look at, from a child and family and provider perspective to see the differences between the 2 settings. And then finally, one of the things that we're looking at in both settings is the financial cost of the hospitalizations, and we're going to get that from our billing department and finance department after the kids are discharged. We're looking at 40 kids, 20 in the children's hospital and 20 in the psychiatric hospital, again with ASD from 6 to 18. And we're randomly assigning these kids to either an active treatment arm or to a control group. And the control group is not a complete control group. We've had to do a lot of training in both the children's hospital and the psychiatric hospital with nurses, with residents, with physicians to help kind of educate them on what behavioral therapies even are sometimes, helping manage their response to some of the behavioral assessments that we've done in the hospital, and we'll talk a little bit more about that in a minute. Again, ASD according to the DSM, and we're looking at specifically challenging behaviors, and there are just a couple of them listed here. And we've had a wide range. When we first started putting this project together, we were thinking specifically more about the kids with aggression. But as this has unfolded, we've seen a lot of different things. We've seen, kids with self-injury, a lot of elopement, escape things. So it's just really broad, and we've learned a lot in doing this. Again, admission to either, and then the parents willing to provide consent. We are asking the parents to fill out a couple of different forms and evaluations for this study, so their participation is essential. A couple of the aims, the specific aims that we have for this study are look at 2 different things. The first one listed here is looking at specifically the child, family, and provider impact of our intervention. Our primary outcome is using the ABC in reduction of challenging behaviors. And some of these secondary outcomes that we're looking at are the CGI and perceptions of care that we're providing to the attending physicians, staff, which is usually nursing, and to family. Also, the second aim is we're looking at the medical and financial benefits from our intervention, with the primary outcome being length of stay, and the secondary outcomes being use of less manual or chemical restraints, decreased staffing ratios, and financial cost. Just a closer look at our specific measurements that we're using. The ABC, we're administering both at admission and discharge and looking at a change between those 2. The CGI S and the CGI I, severity and then improvement scales. We're doing severity at admission, and then both CGI at admission and discharge. And then, like I mentioned before, the perceptions of care are administered to the staff, physician, and caregivers. We're also using our electronic medical record here at Vanderbilt to look at our lengths of stay, sedation, physical medical medication restraints, ratios, and then we've asked our financial department to pull some of the financial data after the kids are discharged. The other thing that we have as part of this study is a 3-month post-follow-up where we're contacting the caregivers of the kids that were in the hospital, looking at things that have changed over the time, looking at different medical conditions, hospitalizations, emergency room visits, and then also we're looking at how the parents were able to implement some of the behavior strategies that they learned in the hospital. You know, in our setting here in Tennessee, we have a very diverse population as far as their accessibility to behavioral therapies. You know, some insurances will provide this as a service, but most will not. So a lot of these families, you know, are able to learn some of these techniques in the hospital and then implement them at home or use them with, you know, the therapist that they have, whereas very few are able to get specific behavior therapists once they leave the hospital. And we're hoping with studies like this we can change that. Our primary analysis plan is to look at 4 different groups with 10 in each group, one, you know, being the Children's Hospital, both active and control, and then the other being the Psychiatric Hospital, both active and control. We're looking at pre and post measures of the ABC and the length of hospitalization for our secondary aim. We're using linear regression to compare the ABC over time, and also with our length of hospitalization, we're looking at the difference between the settings as a possible covariate also. Some other things that we're really interested in are the metrics of behavior change involving, and we're using the CGI, and also the perception of care questionnaires that we've asked our staff and parents to fill out. We're looking, also very interested in looking at specific either increase or decrease in manual chemical restraints while these kids are hospitalized, and the care ratios and financial costs, as we mentioned before. Some of the things that we're also paying attention to, you know, the age of the kids, the gender, additional diagnoses, medications that the children may be on, and other baseline characteristics. And we're putting all these things together to determine if a larger scale like study might be feasible. You know, one of the things that we've noticed in doing this trial is that there are a lot of different needs and concerns that families that are hospitalized have. You know, it ranges really from a very short-term safety evaluation for some of these kids to some of these kids needing a very long-term intervention, respite for family members. You know, we've seen kids that have injured siblings, and the parents are just trying to struggle on how to deal with that. And the behaviors vary tremendously too. The frequency, severity, you know, and we've had kids that, you know, mildly aggressive to kids that are doing very, very dangerous behaviors, not only to themselves but a threat to most family members in the house. And the communication with our specific patients, again, varies tremendously. We have some higher functioning ASD patients that communicate very well or very well for ASD patients, and then some that have minimal or no communication skills. And trying to do this and provide and achieve the same goals has definitely been challenging and a big learning situation for us. One of the first things that we encountered in doing the study was using a non-blinded setting for the behavior treatments. You know, a lot of the families, when we went through the consent and explained the study, when they found out that they were assigned the control arm, there was this huge feeling of rejection and wanting to move forward and wanting us still to help, you know, be able to intervene. So we struggled with, you know, how to manage that during the study. And on the flip side, we had a couple of families that felt like the kids were responding so well to the behavior therapies that they received in the hospital, they really didn't want to discharge. They wanted to get all they could out of this intervention, which, you know, kind of goes against some of our metrics that we were using to measure the efficacy. But again, these are all challenges that we've been trying to sort through. Another thing just to mention, you know, we had some of these kids that were so sick that even our psychiatric hospital felt like the acuity was too high on the unit, or the kids were too sick even to be admitted there. So, you know, a lot of challenges that we've seen. I put staff training down here because, again, I mentioned earlier that, you know, one of the big things for us is, a lot of, specifically the nurses or maybe residents, may not even know what, behavior therapies entail. For instance, like we had a situation where we were doing a functional analysis and the child may get a little bit aggressive or start yelling, and the nurses had a hard time kind of understanding that that was kind of part of the treatment itself, and kind of educating around that has been a challenging process. Also, administering these therapies in a hospital setting is very different than how most ABA therapy and assessments typically done. Hospital rooms often have, expensive electronic equipment, hoses, cords, all kinds of things that could be dangerous if the child gets out of control or has challenging behaviors. So we've had to adapt to that and try to implement ways to kind of almost forecast what we think might happen and make sure that we're in a safe environment to do what we need to do to help these kids. And again, the repetitive cyclic nature of some of these hospitalizations, kids kind of coming in and out or needing help for one reason or another. I listed here some of the ABA models that we've been able to adapt and put into practice since we've been doing the study, and I think John's a lot more qualified than I am to talk about that, so I'm going to switch over to him just for a second to let him talk about these.
I think in the interest of time, I won't go into all of these, but what I want to say is that there are a few of these components that each patient has encountered. We have always begun with an interview in which we've identified the problems that the family wants help with, and then a functional analysis screening tool, which is a well-validated method for hypothesizing what we think is leading to this problem behavior and what we think is reinforcing its ongoing presence. We've always conducted preference assessments in which we determine what are some of the favorite things the child has in their environment that can be used in later assessments. And then all patients have been assessed using a latency-based functional analysis. And the idea is that we take the sorts of situations the family described in their interview that has set off problem behavior at home, and we've simulated that in the hospital setting, essentially to try to confirm or verify what it is that is truly leading to the problem behavior and what it is that seems to be reinforcing it. And some families will tell us we have no idea, and so this is very helpful for them to get some clues. I think in some cases families have ideas, but as we're trying to intervene efficiently, it's important for us to know that we're actually on the right track. I guess some of the other things that you'll see here: patient interviews, concurrent operance assessment, contingency space analysis. All three of those have occurred in situations where no problem behavior has occurred during our functional analysis, and so we've sought out other sources of information to try to get better clues about where our treatment needs to focus. And then items 7 and 8 just refer to the diversity in terms of treatments that we've actually applied. For all patients in our active group, we have targeted communication skills. Even some patients who were very, very verbal, we have always been finding communication deficits that need to be worked upon in order to address these short-term aims. And then our antecedent and consequent-based interventions have been around us trying to remove those things in the environment that have set off problems, and then trying to make sure that we're not reinforcing problem behavior when they do occur. Some lessons that my team have learned, I think that our perception of care and the speed with which we've been able to impact patient discharge has largely hinged on our communication. I think that if medical staff don't know the gains that our patients are making in therapy, I don't know how they would realize that maybe we can move ahead with discharge. For families, we've found that just taking 5 minutes to call families at the end of each day to let them know how therapy went has really, really made their perception of care go up, and I think has made families comfortable with their child coming home sooner. In terms of some of those modifications I just referred to, we've just found that we've needed to be flexible, that this is not a behavior analysis clinic, and so we've needed to work around some of the limitations and strengths of the environment. We've also, everybody on our team have been used to working in more long-term clinical settings or schools where the metric of care is, minimum of maybe a month and onwards to maybe 6 months or a year in terms of how much time we have to maneuver and get things in place. In this case, we've been trying to get patients home as soon as possible, so if we can make a difference in the next 24 or 48 hours, then that's the sort of intervention we need to apply, and we've had to adapt to that. I think also we found that in terms of our assessment and treatment procedures, the diversity of patients, the diversity of problem behaviors, the diversity of opportunities has led us to need to be flexible, and really it's exposed some weaknesses in some of our tools, and I think we found some good replacements when those emerged.
Thank you, John. And again, just kind of going through some of the the things that we hope to accomplish from this is developing long-term models using different behavior assessments in these settings and generalizing this beyond hospitalization, coming up with tools that we can send families home with. And again, training has been very, very crucial to us, and we found that the more we've been able to do it in our study, the better things have gone on the floor and with our patients. And here's where we are so far. We started enrollment in March. We're enrolling until July 17th. We've got almost 30 subjects now, and we're still, our final is the end of August. So that's all we have. Any questions?
Great presentation, Kevin and John. Thanks very much.
Thank you.
We are at the end of our hour, but I think we could probably take one or two questions real quickly.
I don't have any questions for the presenters at this time, but I would encourage, once the email goes around with the links to the recording, to the PowerPoints, we do have a question here. With major military installation nearby, are you seeing any military families in your study? Kevin, I believe.
Yeah, we have seen a few military families in our study. You know, and that is a whole, with some military families, you know, the moving more frequently than normal, some of the changes that happen for some of these kids with a parent maybe being deployed, or you know, not having you know, kind of a more typical work day has been challenging for some of these families. So yeah, we do see those kids, and again, we're trying to make adaptations and help families deal with some of those changes.
Great. Thank you. So I would just encourage folks, there will be an email address on the information that will be sent to you tomorrow, and if you have questions for our presenters, or if you'd like to kind of learn some more about the studies, then you can send an email to that address and I can link you up with the presenters.
That's great.
And that's it.
I want to thank our presenters today and all of you who were able to log into today's webinar, and I hope everybody has a wonderful week and a wonderful 4th weekend. Bye, folks.
Thank you, Dan.
Thank you so much.
Thank you.